Question 1. A nurse is performing a pre-dialysis physical assessment on a patient with an arteriovenous fistula, AVF. Which finding indicates a patent, well-functioning AVF? A. Absence of a bruit on auscultation. B. Extremity is cool to the touch distal to the access site. C. A palpable thrill over the access site. D. Significant arm swelling with collateral circulation. Answer C. A palpable thrill over the access site. This question tests the fundamental concept of vascular access assessment, specifically identifying signs of a patent arteriovenous fistula, AVF, before hemodialysis. The keywords patent, well-functioning are the main clues, indicating you should look for the normal, expected findings. A palpable thrill, which is a vibratory sensation felt over the AVF, and an audible bruit, which is a whooshing sound, are both created by the high-pressure arterial blood mixing with the low-pressure venous blood, confirming a clear and adequate blood flow for dialysis. The absence of a thrill or bruit, or the presence of coolness or swelling, would instead suggest a clotting or stenosis problem that needs immediate intervention. You can remember this by associating thrill with flow. If you feel the thrill, the blood is flowing well. Question 2. A patient reports severe back pain, anxiety, and chest tightness 5 minutes after initiating hemodialysis with a new dialyzer. The nurse observes hypotension and fever. What is the most likely complication? A. Dialysis disequilibrium syndrome. B. Air-embolism. C. First-use syndrome. D. Hypoglycemia. Answer C. First-use syndrome. This item tests the recognition of acute hypersensitivity reactions during hemodialysis, known as first-use syndrome, which is an important safety concept. The key clues are the rapid onset, 5 minutes after initiation, and the classic triad of symptoms: back pain, chest tightness, and dyspnea, often accompanied by hypotension and fever, typically seen when a patient is exposed to a new dialyzer or reprocessing chemical residue. This acute reaction is due to a hypersensitivity response to the dialyzer membrane material or sterilants used during manufacturing, distinct from the gradual neurological symptoms of disequilibrium syndrome or the sudden cardiopulmonary arrest of an air-embolism. If a patient is starting on a new type of dialyzer, it is crucial to observe them closely during the first few minutes of treatment, as this reaction is a true medical emergency. Remember that a reaction starting immediately after blood meets the new filter is often a first-use or hypersensitivity issue. Question 3. What is the primary reason for administering a calcium-containing phosphate binder with meals to a patient on hemodialysis? A. To prevent vitamin D deficiency. B. To increase calcium absorption in the stomach. C. To control serum potassium levels. D. To bind dietary phosphate in the gastrointestinal tract. Answer D. To bind dietary phosphate in the gastrointestinal tract. This question focuses on the pharmacology and nutritional management of chronic kidney disease, CKD, mineral and bone disorder, specifically the function of phosphate binders. The core concept is that impaired kidney function leads to high serum phosphate levels, hyperphosphatemia, because the kidneys cannot excrete it efficiently, so the primary goal of the binder is to control this. The essential clue is with meals, because this timing allows the phosphate binder, such as calcium carbonate, to attach to the phosphate in the food while it is still in the gastrointestinal tract, thereby preventing its absorption into the blood. By limiting the amount of phosphate absorbed, the drug helps keep serum phosphate within the target range, reducing the risk of calcification and bone disease. For example, a patient takes a binder like sevelamer, Renagel, or calcium acetate, Foslo, right before or during a meal to capture the phosphate from the food they are eating. The takeaway is, binders must be taken with the food to bind the dietary phosphate before it gets into the blood. Question 4. The acceptable level for chlorine and chloramine in the water used for hemodialysis is critical because high levels can lead to which complication in the patient? A. Metabolic acidosis. B. Hemolysis. C. Severe hyperkalemia. D. Calciphylaxis. Answer B. Hemolysis. This question tests knowledge of the critical water treatment component of hemodialysis, specifically the danger of disinfectants like chlorine and chloramine. High concentrations of these chemicals in the dialysate water are toxic and can damage the red blood cells as blood passes through the dialyzer. This cellular damage results in hemolysis, the destruction of red blood cells, which can lead to severe anemia and potentially life-threatening hyperkalemia if the potassium leaks out of the destroyed cells. This is why the use of granular activated carbon GAC tanks, carbon filters, is mandatory to remove these oxidants before the water is mixed into the dialysate, and why testing for these agents must be done before the start of each patient day. Remember that chlorine and chloramine are cell-destroying toxins that can cause red blood cells to burst, hemolysis, and must be completely removed from the water. Question 5. The most common cause of hypotension during a hemodialysis treatment is A. Dialyzer clotting. B. Rapid removal of a large volume of fluid. C. Blood leak in the dialyzer. D. Inaccurate sodium modeling in the dialysate. Answer B. Rapid removal of a large volume of fluid. This question addresses the most frequent and important complication a dialysis nurse must manage: intradialytic hypotension, which is a major concept in patient safety. The key clue here is the context of during a hemodialysis treatment, where the main focus is on the ultrafiltration process. Rapid removal of fluid, ultrafiltration, at a rate faster than the body's vascular refill rate causes a drop in the patient's circulating blood volume, leading to a compensatory drop in blood pressure. Managing the ultrafiltration rate and setting an accurate target weight, dry weight, are the primary interventions to prevent this, and interventions to correct it often involve slowing down the fluid removal and administering a bolus of intravenous saline. For example, removing 3 liters of fluid over 3 hours instead of 4 can increase the risk of the patient's blood pressure dropping from 140/80 to 90/50. The core takeaway is that the main cause of low blood pressure during treatment is removing too much fluid too quickly. Question 6. When preparing a patient for a peritoneal dialysis D exchange, the nurse notes cloudy effluent. What is the nurse's priority action? A. Send a sample of the effluent for cell count and culture. B. Immediately increase the dwell time of the next exchange. C. Administer a high-dose oral laxative. D. Change the dialysate solution to a lower dextrose concentration. Answer A. Send a sample of the effluent for cell count and culture. This question tests the essential safety concept of recognizing and responding to peritonitis, which is the most serious complication of peritoneal dialysis D. The key clue is cloudy effluent, which is the cardinal sign of an infection in the peritoneal cavity, signaling peritonitis until proven otherwise. The priority action is to definitively diagnose the infection by obtaining a specimen of the effluent for laboratory analysis, specifically for cell count and culture, to identify the causative organism and guide antibiotic therapy. Delaying diagnosis and treatment can lead to severe systemic infection and PD catheter loss, so diagnostic testing must occur immediately, well before any treatment adjustments are made. For instance, the PD unit would have a standing order for empirical antibiotic therapy to begin as soon as the cloudy fluid is confirmed. Always remember that cloudy fluid in PD means peritonitis until proven otherwise, and the first step is to get a sample for the lab. Question 7. A patient on hemodialysis has a hemoglobin B of 8,5G/DL. The nurse administers epoetin alpha, an erythropoiesis-stimulating agent or ESA. The primary goal of this therapy is to A. Decrease the patient's phosphorus levels. B. Treat anemia by stimulating red blood cell production. C. Improve bone mineral density. D. Prevent clotting in the vascular access. Answer B. Treat anemia by stimulating red blood cell production. This question assesses the fundamental understanding of the pharmacological management of renal anemia, a core concept in dialysis care. The key is recognizing epoetin alpha, or epigen, as an erythropoiesis-stimulating agent (ESA), which mimics the natural hormone erythropoietin the failing kidneys no longer produce adequately. The primary goal of administering this medication is to correct the patient's anemia by stimulating the bone marrow to produce more red blood cells, thereby improving oxygen-carrying capacity and quality of life. The effectiveness is typically monitored by checking the hemoglobin and hematocrit levels, with a target HGB level, generally between 10 and 11 5G/DL, to minimize associated risks like stroke. To easily remember this, just think epoetin alpha is for EPO, which stands for erythropoietin, the hormone that makes red blood cells. Question 8. A patient on hemodialysis is complaining of shortness of breath and has peripheral edema. The nurse notes the patient's pre-dialysis weight is 3-5 kg above their established dry weight. The primary goal of the next hemodialysis treatment should be to A. Increase the dialysate bicarbonate concentration. B. Administer an iron supplement intravenously. C. Achieve the estimated dry weight by removing excess fluid. D. Monitor for signs of dialysis disequilibrium syndrome. Answer C. Achieve the estimated dry weight by removing excess fluid. This scenario tests the critical concept of fluid management and dry weight, which is central to a dialysis nurse's assessment and treatment plan. The clues, shortness of breath, peripheral edema, and 3-5 kg above their established dry weight, all point to a state of fluid volume overload, the primary problem to address. The fundamental goal of the hemodialysis treatment is to safely remove this excess fluid via ultrafiltration until the patient is at their dry weight, which is the weight at which they are euvolemic, have normal fluid volume, without signs of hypertension or hypotension. Failure to remove the excess fluid increases the risk of congestive heart failure and pulmonary edema, so setting the ultrafiltration goal to remove 3-5 kg is the most critical intervention. The takeaway is, fluid overload is always the first priority in a symptomatic patient who is significantly above their dry weight. Question 9. The nurse assesses a patient's arteriovenous graft, AVG, and finds that the thrill is absent and the site is cool, pale, and painful. The nurse should immediately suspect which complication? A. Venous stenosis. B. Steele syndrome. C. Access thrombosis. D. High-output cardiac failure. Answer C. Access thrombosis. This question tests the nurse's ability to recognize the signs of a clotted or thrombosed vascular access, a critical emergency concept. The keywords "thrill is absent" are the most important clue, as the loss of a thrill or bruit indicates that blood flow through the graft has stopped or is severely reduced. The additional signs of cool, pale, and painful suggest a lack of blood flow, which in the context of a dialysis access indicates thrombosis, clotting, within the graft, requiring immediate intervention to save the access. While Steele syndrome, blood being diverted from the handy, can cause coolness and pallor, it does not typically cause the complete, sudden loss of the thrill, making thrombosis the more acute and likely diagnosis here. A key takeaway is that an AVF or AVG without a palpable thrill is always a non-functioning access that needs urgent attention to restore blood flow. Question 10. Which action is the most important step a nurse can take to prevent central line-associated bloodstream infections, CLABSIs, in a patient with a tunneled hemodialysis catheter? A. Administering prophylactic antibiotics before each treatment. B. Ensuring the patient wears a mask during catheter access and dressing changes. C. Routinely applying antibiotic ointment to the exit site. D. Strictly adhering to a septic technique during all catheter manipulations. Answer D. Strictly adhering to a septic technique during all catheter manipulations. This question emphasizes the core infection control principle in dialysis, which is the most effective method for preventing CLABSIs. A septic technique, using sterile procedures, including proper hand hygiene, sterile gloves, and a sterile field, is the single most important intervention to prevent microorganisms from entering the bloodstream during the preparation, connecting, and disconnecting of a central venous catheter, CVC. While wearing a mask, as is standard practice for the patient and staff, is part of the procedure, it is the strict adherence to a sterile process that provides the highest level of defense against introducing bacteria from the skin or environment into the catheter lumen. This rigorous practice minimizes the entry of pathogens, drastically reducing the risk of a life-threatening blood infection. You can remember this by realizing that the most effective way to prevent infection is by preventing the germs from getting in, which is the purpose of a septic technique. Question 11. What is the primary method by which waste products, such as urea and creatinine, are removed from the blood during a typical hemodialysis treatment? A. Ultrafiltration. B. Osmosis. C. Convection. D. Diffusion. Answer D. Diffusion. This question tests the foundational principle of hemodialysis clearance, which is essential for understanding how the treatment works. The key waste products mentioned, urea and creatinine, are small molecules that are present in high concentration in the patient's blood and low concentration, or absent, in the dialysate. Diffusion is the passive movement of solutes, the waste particles, across a semi-permeable membrane, the dialyzer, from an area of higher concentration, bloody, to an area of lower concentration, dialysate. Although ultrafiltration and convection remove some waste, the vast majority of small solute clearance is achieved through the process of diffusion, driven by the concentration gradient across the membrane. Think of diffusion as the primary cleanup crew for metabolic waste, making it the most important process for toxin removal in standard hemodialysis. Question 12. A patient on peritoneal dialysis reports abdominal pain, and the nurse observes that the inflow is slow and difficult. The first intervention should be to A. Immediately remove the PD catheter. B. Administer 4 narcotics for the pain. C. Check for kinks or closed clamps in the transfer set. D. Increase the dextrose concentration of the dialysate. Answer C. Check for kinks or closed clamps in the transfer set. This question assesses the initial troubleshooting steps for common mechanical problems in peritoneal dialysis, a critical skill for the nurse. The key clues are slow and difficult inflow, which points to an obstruction or mechanical issue rather than a biological complication like infection. Before assuming a complex issue, the nurse should always check the most common and easiest to fix mechanical causes, such as a kink in the tubing or a clamp that was left closed on the transfer set. Resolving a simple mechanical obstruction often immediately corrects the inflow and outflow problems, preventing the need for more invasive or unnecessary interventions. For example, the patient might have rolled over and kinked the tubing under their body, which is easily corrected with repositioning. Always remember to check the tubing and clamps first, as simple mechanical issues are the most frequent cause of flow problems. Question 13. Which laboratory value is most indicative of the adequacy of a patient's hemodialysis treatment? A. Serum calcium. B. Hemoglobin. B. C. KT/V. D. Serum albumin. Answer C. KT/V. This question tests a crucial measure in dialysis care, the concept of dialysis adequacy. The keyword adequacy is the direct clue to the correct answer, which is the KT/V, where K equals dialyzer clearance, T equals time, and V equals volume of distribution. The KT/V is a mathematical formula used to quantify the amount of urea removed from the patient's body during a dialysis session, and the resulting number is the standard metric used worldwide to determine if the patient is receiving an effective dose of dialysis. While all the other options are important labs, they measure nutrition, anemia, or bone health, not the direct effectiveness of the waste removal process itself. The takeaway is that KT/V is the gold standard measurement for determining if the dialysis treatment is actually sufficient in cleaning the patient's blood. Question 14. What is the highest acceptable level of aluminum in the finished water used to prepare dialysate, according to AAMI standards? A. 0.1 mg/L. B. 0.01 mg/L. C. 0.05 mg/L. D. 0.001 mg/L. Answer B. 0.01 mg/L. This question tests a specific, high-stakes standard in the area of dialysis water treatment, which is essential for patient safety. Aluminum is a trace element that can be toxic to dialysis patients, leading to dialysis dementia and bone disease if allowed to enter the dialysate. According to the Association for the Advancement of Medical Instrumentation (AMI) standards, the acceptable level for aluminum in the final dialysate water must be less than 0.01 mg/L or 10 micrograms per liter. Because the water is directly mixing with the patient's blood during treatment, these limits are much stricter than those for standard drinking water to prevent the chronic accumulation of toxins. To make this easy to remember, Realize that for the final treated water, the AMI limits for all trace contaminants are extremely low and often measured in hundredths of a milligram or micrograms, with aluminum being a critical one to know. Question 15. A patient undergoing hemodialysis suddenly develops restlessness, confusion, headache, and nausea during the first hour of treatment. The nurse should suspect which complication? A. Hypoglycemia. B. Air-embolism. C. Dialysis disequilibrium syndrome, DDS. D. Anaphylaxis. Answer C. Dialysis disequilibrium syndrome, DDS. This question addresses the important acute neurological complication known as dialysis disequilibrium syndrome, DDS, which is a key concept in hemodialysis. The main clue is the collection of nonspecific neurological symptoms like restlessness, confusion, headache, and nausea occurring during the first hour of dialysis. DDS is typically caused by the rapid removal of urea from the blood, creating an osmotic gradient that causes fluid to shift into the brain cells, which can cause swelling and neurological symptoms. It is most common in new patients or those with very high pretreatment blood urea nitrogen, BUN levels. If you see new neurological changes starting early in the treatment, suspect DDS and notify the physician for potential treatment modifications like a slower blood flow rate. Question 16. To prevent air from entering the patient's bloodstream, where should the nurse set the level in the venous air trap, drip chamber? A. Completely full of blood. B. Halfway full of blood. C. Near the top of the chamber, but not full. D. Completely empty of blood. Answer C. Near the top of the chamber, but not full. This question tests the essential safety and circuit management concept related to preventing an air-embolism, a life-threatening complication. The key is understanding the function of the venous air trap, which is the last point of protection before the blood returns to the patient. The blood level should be high near the top to provide the longest distance possible between the air fluid interface and the venous access line, ensuring that any residual air bubbles collect at the top and are not pulled into the patient's vein. However, the chamber must not be completely full, as this would eliminate the air trap function and could trigger a false venous pressure alarm if a minor clot or access flow issue occurs. An easy way to recall this is to keep the venous drip chamber almost full, to give the air a large surface area to escape without spilling over to the patient. Question 17. The nurse notes a patient's pre-dialysis blood pressure is 178/96 mmHg. The priority action related to the dialysis treatment should be to A. Hold the patient's pre-dialysis blood pressure medications. B. Contact the physician to verify ultrafiltration goal and dry weight. C. Increase the dialysate temperature for patient comfort. D. Reduce the prescribed blood flow rate. B. Answer B. Contact the physician to verify ultrafiltration goal and dry weight. This question assesses the nurse's critical thinking regarding hypertensive management in dialysis patients. The keyword priority action requires the nurse to address the root cause of the patient's hypertension, which in the dialysis setting is frequently related to fluid volume overload. A blood pressure of 178/96 mmHg warrants an immediate reassessment of the patient's dry weight and the required ultrafiltration goal for the day, as achieving the correct fluid removal is the most powerful tool for blood pressure control. While blood pressure medication may be held or adjusted, the nurse's priority is to collaborate with the prescriber regarding the overall fluid and blood pressure management plan before simply holding medications or adjusting the treatment machine settings. The takeaway is, never assume high blood pressure is just a medication issue. Always check for fluid overload and dry weight accuracy first. Question 18. Which statement best describes the primary action of unfractionated or low molecular weight heparin, LMWH, when used for anticoagulation during hemodialysis? A. To dissolve clots that have already formed in the blood circuit. B. To prevent the formation of new clots within the extracorporeal circuit. C. To correct anemia by improving blood flow through the dialyzer. D. To reverse the effects of protamine sulfate. Answer B. To prevent the formation of new clots within the extracorporeal circuit. This question tests the foundational knowledge of anticoagulation pharmacology in the dialysis setting. The primary purpose of administering heparin, whether unfractionated or LMWH, is not to break down existing clots, but to prevent the blood from clotting as it travels through the non-native materials of the extracorporeal circuit, tubing, dialyzer, and air trap. Heparin achieves this by acting on the coagulation cascade, specifically by binding to antithrombin and inhibiting the formation of fibrin, thereby maintaining the patency of the blood circuit throughout the treatment. The use of heparin ensures the blood flow remains smooth and prevents the dialyzer from prematurely clotting off, which would terminate the treatment early. Remember this. Heparin is a preventative measure. It stops new clots from forming so the machine can run safely. Question 19. A patient is prescribed a fluid restriction of 1,000 milliliters per day plus their urine output. The purpose of this strict restriction is primarily to A. Ensure adequate dialysis clearance. B. Prevent complications associated with intradialytic weight gain. C. Reduce the risk of hyperkalemia. D. Stabilize the patient's blood glucose levels. Answer B. Prevent complications associated with intradialytic weight gain. This question addresses the critical concept of fluid management and patient education, focusing on the purpose of strict fluid restriction. The primary reason for a fluid restriction in an anuric, non-urinating, or oliguric, low-urinating dialysis patient is to limit the amount of fluid accumulation between treatments. Controlling the interdialytic weight gain prevents the development of fluid volume overload, which can lead to severe complications such as pulmonary edema and congestive heart failure. The fluid goal is carefully calculated to allow for normal body metabolism while controlling weight gain, ensuring that no more than 3 to 5% of the dry weight is gained between treatments. The takeaway here is that limiting fluid is essential to keep the heart and lungs healthy and prevent dangerous fluid overload between sessions. Question 20. Which term describes the movement of fluid across a semi-permeable membrane due to an applied pressure gradient, negative or positive? A. Diffusion. B. Osmosis. C. Convection, solvent drag. D. Ultrafiltration. Answer D. Ultrafiltration. This question clarifies the mechanism of fluid removal, which is a key concept in the hemodialysis process. Ultrafiltration is specifically defined as the process of removing fluid from the blood by applying a pressure gradient, hydrostatic pressure, across the semi-permeable membrane of the dialyzer. In hemodialysis, the machine controls this pressure to actively pull excess plasma water from the patient's blood into the dialysate compartment. While osmosis is the passive movement of water due to concentration differences, ultrafiltration uses mechanical pressure, the UF rate, to force the fluid out, making it the primary method of achieving the fluid removal goal. Remember that ultrafiltration is the technical term for the controlled, forced removal of excess water from the blood during dialysis. Question 21. Which type of dialysis access is considered the gold standard due to its low complication rates and long-term patency? A. Arteriovenous fistula, AVF. B. Non-tunneled central venous catheter, CVC. C. Arteriovenous graft, AVG. D. Tunneled cuffed central venous catheter. Answer A. Arteriovenous fistula, AVF. This question tests the essential knowledge of vascular access options, which is a foundational concept in renal nursing. The arteriovenous fistula, AVF, is created by surgically connecting a patient's artery to a vein, and it is universally considered the gold standard access. This preference is due to its low rates of infection and thrombosis, clotting, compared to grafts and catheters, as well as its superior long-term survival and lower intervention rates. While an AVF takes the longest to mature, its durability and safety profile make it the preferred permanent access choice for all patients when medically possible. The takeaway is, a fistula AVF is the first and finest choice for long-term dialysis access due to its natural patency and low risk of infection. Question 22. A patient on continuous ambulatory peritoneal dialysis, CAD, reports feeling full and bloated with a decreased appetite. What is the most likely cause of these symptoms? A. Poor clearance from the dialyzer. B. Low serum albumin levels. C. Large volume of dialysate dwelling in the peritoneal cavity. D. Excess intradialytic fluid weight gain. Answer C. Large volume of dialysate dwelling in the peritoneal cavity. This question addresses the common physical complaints associated with peritoneal dialysis, D, due to the mechanics of the treatment. The core concept here is that PD involves instilling a large volume of dialysate, typically 5 to 3 liters, into the patient's abdominal, peritoneal cavity for a set dwell time. The physical presence of this fluid volume distends the abdomen, which puts pressure on the stomach and intestines, resulting in the feeling of fullness and bloating, and leading to a decreased appetite. This feeling is not related to dialyzer clearance or fluid weight gain, and is a normal, albeit uncomfortable, side effect of having the prescribed dialysate dwelling in the abdomen. A practical tip is to advise patients to manage this discomfort by draining the dialysate before a meal. Question 23. The primary reason for performing cannulation site rotation when using an arteriovenous fistula, AVF, is to A. Minimize the risk of localized infection. B. Prevent the development of aneurysms and pseudoaneurysms. C. Increase the overall blood flow rate. B. D. Decrease the patient's pain during needle insertion. Answer B. Prevent the development of aneurysms and pseudoaneurysms. This question tests the crucial concept of preserving the vascular access, a key responsibility of the dialysis nurse. Repetitive cannulation, needling, into the exact same small area over time causes weakness in the vessel wall, leading to dilation, which can progress to potentially dangerous aneurysms or pseudoaneurysms. Site rotation, or using the rope and ladder technique, ensures that the entire length of the usable fistula is utilized for cannulation, allowing previous sites to heal and preventing localized weakening of the access vessel. While site rotation may also help with pain and infection risk, the primary goal is access longevity and preventing the structural complications that could lead to access loss. The takeaway is, the rope and ladder method saves the access by distributing the needle sticks and protecting the blood vessel wall. Question 24. A patient is confused, dizzy, and their potassium level is 6.5 milliequivalent/L. The most immediate life-saving intervention a nurse can anticipate or administer before dialysis begins is A. A dose of epoetin alpha. B. Intravenous regular insulin and dextrose. C. Intravenous iron sucrose. D. A phosphate binder with a glass of water. Answer B. Intravenous regular insulin and dextrose. This question tests the crucial emergency response for severe hyperkalemia, a life-threatening electrolyte imbalance. The key clue is the critically high serum potassium level of 6.5 milliequivalent/L, which can lead to fatal cardiac arrhythmias. The immediate goal is to rapidly shift potassium from the blood into the cells, and the combination of intravenous regular insulin, which drives potassium into the cells, and dextrose, to prevent hypoglycemia, is the fastest and most effective temporary measure to protect the heart. While dialysis is the definitive long-term treatment, the insulin/dextrose protocol provides immediate cellular level stabilization to buy time until the patient can be connected to the dialysis machine. Always remember that a critical potassium level requires immediate cardiac stabilization with medications like calcium gluconate and the insulin dextrose protocol. Question 25. Which dialysate component is adjusted to help correct metabolic acidosis, a common consequence of kidney failure? A. Calcium. B. Dextrose. C. Bicarbonate. D. Potassium. Answer C. Bicarbonate. This question focuses on the composition of the dialysate and its role in correcting acid-base imbalances, an essential component of the dialysis prescription. Metabolic acidosis is a hallmark of kidney failure because the kidneys fail to reabsorb or generate bicarbonate, the body's main buffer, and excrete acid. Dialysate, therefore, contains bicarbonate or an acetate equivalent that the liver converts to bicarbonate at a higher concentration than the patient's blood, which then diffuses into the patient to replenish the buffer stores and normalize the blood pH. Adjusting the dialysate bicarbonate concentration is the main mechanism by which hemodialysis corrects the patient's chronic metabolic acidosis. The easy way to remember this is: bicarbonate is the primary ingredient used to treat acidosis. Question 26. Which finding is the most concerning sign of a potential infection at the exit site of a tunneled dialysis catheter? A. Mild serous drainage without redness. B. Erythema, redness, extending more than 2 centimeters from the exit site. C. Patient reporting minor tenderness upon palpation. D. Presence of old, dried blood under the dressing. Answer B. Erythema, redness, extending more than 2 centimeters from the exit site. This question tests the nurse's ability to assess and differentiate between minor irritation and significant catheter-related infection, a key component of infection control. While mild redness and tenderness can be minor irritations, erythema, redness, that extends significantly beyond the exit site and may be accompanied by purulent drainage is a hallmark sign of a serious local infection. This finding suggests cellulitis or a tunnel infection, which is a precursor to a life-threatening bloodstream infection, CLABSI, and requires immediate intervention, typically including systemic antibiotics. For example, a track of redness going up the chest wall from the exit site would be a critical finding. The key takeaway is, spreading redness and pus are always the most critical signs of a progressing infection that demands prompt reporting and treatment. Question 27. During hemodialysis, the nurse notes the venous pressure alarm is repeatedly sounding at a high pressure. After checking for kinks, what is the next most likely cause? A. Dialyzer clotting. B. Air in the venous drip chamber. C. Venous needle infiltration or stenosis of the axis. D. Insufficient blood flow rate. B. Answer C. Venous needle infiltration or stenosis of the axis. This question assesses the nurse's troubleshooting skills related to the extracorporeal circuit alarms, a necessary skill for treatment safety. A high venous pressure alarm means there is increased resistance after the blood pump, hindering the blood's return to the patient, with the venous needle tip or the access itself being the final limiting factor. The key clue high pressure points to an obstruction, and after ruling out a simple tubing kink, the most common causes are a positional or partially occluded venous needle, or a significant stenosis, narrowing of the patient's vascular access vein leading to a high resistance. A clot in the dialyzer option A would typically trigger a low blood flow or a high arterial, pre-pump pressure alarm, not a venous pressure alarm. The takeaway is, high venous pressure usually means an obstruction between the pump and the patient, most often at the venous needle or in the patient's access vein. Question 28. Which complication is most likely to occur if a patient's prescribed dialysate temperature is set to high, e.g., above 37.0 C? A. Air-embolism. B. Hemolysis. C. Hypotension. D. Dialyzer membrane rupture. Answer C. Hypotension. This question tests the understanding of dialysate temperature effects on the patient's hemodynamics. An excessively high dialysate temperature causes vasodilation, widening of blood vessels, in the patient, as the body attempts to cool itself down through heat transfer across the dialyzer. This widespread vasodilation leads to a drop in systemic vascular resistance, which in turn causes the patient's blood pressure to drop, potentially causing intradialytic hypotension. For this reason, many dialysis units use lower or cool dialysate temperatures, 35.5 C to 36.0 C, to help maintain blood pressure during fluid removal. Always remember that a higher than normal dialysate temperature can warm up the patient, which causes blood vessels to relax, leading to low blood pressure. Question 29. A new patient is starting hemodialysis. The nurse should include which statement regarding the patient's residual kidney function? RKF? A. RKF is not relevant once a patient starts dialysis. B. Preserving RKF is important as it is a major predictor of patient survival and quality of life. C. RKF can be completely restored with adequate dialysis treatments. D. RKF is measured only by a 24-hour urine collection and is rarely accurate. Answer B. Preserving RKF is important as it is a major predictor of patient survival and quality of life. This question addresses the important concept of residual kidney function, RKF, which often gets overlooked when a patient starts dialysis. Even a small amount of residual kidney function provides significant benefits, including better fluid and electrolyte balance, higher small molecule clearance, and better overall quality of life and survival rates than dialysis-only clearance. Because of this benefit, the goal is always to preserve the remaining kidney function for as long as possible, sometimes by delaying or modifying the start of dialysis. The practical example is that patients with good RKF can often have more flexible dietary and fluid restrictions. The takeaway is, even a small amount of urine output is a significant asset to the patient's health and survival. Question 30. During the rinsing back procedure, the arterial bloodline separates from the catheter hub. What is the nurse's immediate priority action? A. Immediately clamp both the venous and arterial lines. B. Notify the physician immediately. C. Start a stat-4 infusion of normal saline. D. Completely remove all blood from the extracorporeal circuit. Answer: A. Immediately clamp both the venous and arterial lines. This question tests the critical concept of patient safety and emergency response to a bloodline separation, which can lead to rapid blood loss or an air-embolism. The priority is to stop the immediate threat to the patient's life, which is the massive blood loss from the open arterial line and the risk of air entrainment through the open venous line. If a central catheter is used, D. Clamping both lines immediately isolates the patient from the circuit, containing the blood and preventing a fatal hemorrhage or air embolism, while the nurse calls for help and attempts to reconnect or secure the line. The takeaway is, the absolute first step in a line separation is to immediately pinch and clamp the patient's bloodlines to stop blood loss and air entry. Question 31. A patient with CKD is receiving intravenous iron sucrose, Venofer. Which lab value is the primary indicator of the effectiveness of 4-iron therapy? A. Serum calcium. B. Ferritin and transferrin saturation, TSAT. C. Blood urea nitrogen, BUN. D. Serum potassium. Answer: B. Ferritin and transferrin saturation, TSAT. This question focuses on the monitoring parameters for treating iron deficiency in dialysis patients, a key concept in anemia management. Intravenous iron is administered to replenish the body's iron stores, which are necessary for the effective functioning of erythropoiesis-stimulating agents, ESAs, like epoetin alpha. The most direct and reliable lab values for assessing the body's iron storage, ferritin, and the amount of iron available for red blood cell production, transferrin saturation, or TSAT, are the primary indicators of whether the 4-iron therapy is working. If these values are low, the iron dose needs to be adjusted. If they are too high, the iron may be paused to prevent iron overload. Remember that when assessing 4-iron treatment, you are checking the patient's iron stores, which are measured by ferritin and TSAT. Question 32. What is the most common electrolyte imbalance seen in a patient presenting for an unscheduled hemodialysis treatment due to non-adherence? A. Hypocalcemia. B. Hyponatremia. C. Hyperkalemia. D. Hypomagnesemia. Answer: C. Hyperkalemia. This question tests the nurse's knowledge of the common acute, life-threatening effects of missed or inadequate dialysis. The keywords unscheduled hemodialysis and non-adherence point to the patient having missed treatments, which means the kidneys have not been cleared of accumulating electrolytes. Because the failed kidneys cannot excrete potassium, the most dangerous and common buildup is hyperkalemia, which is immediately life-threatening due to the risk of cardiac arrest. While other electrolytes may be off, the most acute concern requiring emergency dialysis is typically hyperkalemia. For example, a patient who missed a weekend treatment and ate a high-potassium meal would likely present to the emergency room with critical hyperkalemia. The takeaway is, missed dialysis leads to a buildup of toxins and electrolytes, with potassium being the most life-threatening. Question 33. The principle of convection, solvent drag, is responsible for the removal of what size of solutes during high-efficiency dialysis? A. Small molecules only, e.g., urea. B. Medium and larger molecules, e.g., beta-2 microglobulin. C. Electrolytes only, e.g., sodium. D. Fluid, water, only. Answer B. Medium and larger molecules, e.g. beta-2 microglobulin. This question distinguishes between the clearance mechanisms in dialysis, a concept important for understanding dialyzer performance. Convection, also known as solvent drag, occurs when the substantial movement of water, ultrafiltration, across the dialyzer membrane physically drags solutes along with it. While diffusion is best for small solutes like urea, convection becomes the primary mechanism for effectively removing medium to large-sized molecules, such as beta-2 microglobulin, which can contribute to dialysis-related amyloidosis. This mechanism is especially utilized in high-flux dialyzers and techniques like hemodiafiltration. Remember this. Convection is simply a physical process where the water drag helps to clean out the medium-sized waste particles. Question 34. What is the appropriate needle angle for cannulating an established arteriovenous fistula, AVF, for hemodialysis? A. 5 to 10 degrees. B. 15 to 25 degrees. C. 45 to 60 degrees. D. 90 degrees. Answer B. 15 to 25 degrees. This question tests the essential technical skill and knowledge required for safe vascular access cannulation. The appropriate needle angle for a mature, established AVF is a shallow insertion, typically between 15 and 25 degrees, with a target of 20 degrees. This shallow angle is necessary to smoothly enter the wall of the vessel without passing through the backwalling, and to ensure the sharp point of the needle remains inside the lumen, minimizing trauma and the risk of infiltration. For example, a needle inserted at a 45-degree angle is more likely to cause significant vessel damage and pain. The takeaway is, always use a shallow angle around 20 degrees to ensure a smooth, clean insertion that protects the vessel wall. Question 35. What is the most common cause of muscle cramps that occur late in the hemodialysis treatment? A. High dialysate sodium concentration. B. Excessive and rapid ultrafiltration, fluid removal. C. Low dialysate temperature. D. Hemolysis due to water treatment issues. Answer B. Excessive and rapid ultrafiltration, fluid removal. This question addresses the common and uncomfortable complication of intradialytic muscle cramps. The key clue is the timing. Late in the hemodialysis treatment, which is when the maximum amount of fluid has been removed. Muscle cramps are most frequently caused by the rapid removal of sodium and water, which results in volume depletion and changes in the muscle and nerve blood flow and excitability. Reducing the ultrafiltration rate and administering a small saline bolus are the primary interventions to prevent and treat these cramps. To easily remember this, associate the most common late treatment complaint, cramps, with the most common treatment event, rapid fluid removal.